My name is Allie Tierney, and I'm going to discuss my evidence-based practice project on the topic of heart failure and telemonitoring. According to the American Heart Association, heart failure is the leading cause of hospitalization in the U.S. in individuals over the age of 65. In addition to the prevalence of the disease, heart failure is also a challenging disease to manage due to its complexity and a multitude of other variables. With the implementation of the Affordable Care Act by the federal government, reimbursement for heart failure readmissions within the 30-day period post-discharge is dwindling. In light of the decrease in reimbursement for hospitals, heart failure programs are implementing changes to current practice to prevent frequent readmissions. My clinical practice problem stems from the decreasing reimbursement with the goal of preventing readmission to the hospital by implementing an outpatient telemonitoring program for heart failure patients. Which leads me to my question. In patients over the age of 65 with heart failure, can implementation of an outpatient telemonitoring program prevent heart failure-related hospital admissions 30 days post-discharge? After reviewing the results of the 8 studies, the outcomes vary, making it more challenging to advise a change in clinical practice. 5 of the studies found no statistical difference in 30-day readmission rate with the implementation of a telemonitoring program, whereas 3 studies found a statistically significant decrease in readmission rate 30 days post-discharge. Of the 8 studies I examined, 6 of the studies were randomized controlled trials, and therefore were level 1 sources according to the hierarchy of clinical evidence. 5 of the 6 randomized controlled trials determined that telemonitoring had no statistically significant effect on readmission rate. Of the 3 studies that did find improvement in readmission rate, the strength of the evidence varied. These included one of each of the following: a level 1 source, a level 2 source, and a level 3 source. Because of the distribution of evidence strength as discussed, and for the reasons I will further address, I am not recommending the implementation of a telemonitoring program at this time for the purpose of 30-day readmission rate reduction. There were many inconsistencies and barriers to implementation across the studies I found that could suggest why the results were variable. First, across the studies, there were inconsistent definitions of telemonitoring, which included the measurement of different parameters for each study. For example, in the study by Blum and Gottlieb, the intervention group transmitted their weight, blood pressure, heart rate, and a 50-second EKG strip daily, but no description of symptoms or a completed symptom survey by the patient. In comparison, the Wakefield study used daily patient data transmissions, which included a heart failure symptom checklist: weight, blood pressure, ankle circumference, and abdominal circumference. The next inconsistency noted across studies includes the definition of usual care for the control group as compared to the intervention group. In many of the studies, usual care still involved intensive heart failure education, frequent visitation by medical professionals, and reaching an optimal medication regimen prior to beginning the study. In comparison to older studies which showed more positive results from telemonitoring, has the usual care of patients improved to the point that there is a smaller difference between well-managed usual care patients and telemonitored patients? Does usual care vary from institution to institution and from one provider to the next? In the largest study I reviewed, the results by Chandra were the most disappointing. The results showed no significant decrease in 30-day hospital readmission, but also showed the lowest patient compliance rate across the studies, which could explain why there was no benefit to telemonitoring seen. Patient compliance with the telemonitoring program was seen to affect many of the outcomes and will continue to be one of the largest barriers to implementation of similar programs. In addition to patient compliance and maintaining consistency in telemonitoring and usual care, the final barrier to implementation is cost. Some of the studies included a cost analysis of utilizing the telemonitoring program. For example, the same study by Blum and Gottlieb found that although 30-day readmissions decreased, telemonitoring did not result in lower total costs or better outcomes. To implement the telemonitoring program, the equipment must be purchased in addition to funding equipment set up by technicians. Costs for clinicians to provide education to patients, review and trend data, and contact patients accordingly must also be considered. In future studies, cost analysis should be considered, and ultimately the goal of the CMS change in reimbursement is due to the high cost of heart failure readmissions. As mentioned before, one of the directions research can focus on is related to cost analysis. Although patient outcomes are most important, the reason so much emphasis is being placed on preventing heart failure readmissions is due to the CMS change in reimbursement. 5 of the studies did find a significant improvement in the patient's quality of life, increased understanding of disease, and improved perception of self-maintenance. Unfortunately, that is most likely not enough. If cost and mortality do not improve with the monitoring, it may be difficult to justify the implementation of a telemonitoring program. It was also interesting to see the variation in samples across the studies. Samples were all similar in age. However, only 2 of the studies captured a large sample spanning across the U.S. or across multiple countries. My particular interest in future research includes the use of telemonitoring for patients in underserved rural areas. Although the Hershey Medical Center is located near more populated suburban areas, many of our patients and my population of interest live further from their heart failure clinic. Would telemonitoring be more beneficial for them as opposed to those who can be quickly seen in the clinic setting? With the increasing awareness of heart failure readmission rates, more research should be conducted with underserved patients in rural locations, and more studies should include the cost-benefit of telemonitoring. Nursing research and the dependence on evidence-based practice has allowed our profession to gain ground as a well-respected practice based on science. In order to continue to grow and provide the best care for our patients, nursing researchers need to stay competitive and provide study outcomes to supplement the results of studies from other disciplines in the medical field. A decline in nursing research would lead to stagnancy in the treatment of diseases, and patients would decrease the standards of nursing care. Although there is often a lag between research and implementation in practice, we must continue to conduct studies and promote evidence to provide the best outcome for our patients. Thank you.